Next speaker is Paul Tang, and he's going to talk on the area of the electronic health record and the patient health record. Paul?
All right, thanks, Dominique. And I was so inspired also by John's talk in setting up the infrastructure. Thought our talks were actually very complementary, and we can continue the discussion this morning on the patient portal kinds of things. But first, I need to acknowledge the sources of my integrative thinking, and these are my two kids. One is a senior in high school and about to go off to college, we hope, next year, and the other is 11 years old. And they're sharing knowledge and world knowledge along the beach. And the question, of course, is who's advising whom? I do know that they both advise me in terms of what I need to say and where I get my wisdom. So what I'd like to cover is really this: why are we getting into this space? John talked about how complex it is, and the healthcare isn't all at fault. It really is a truly complex problem. What's brought it to the fore is this patient safety initiative, and how electronic health records plays a big role in pushing that agenda, and particularly the personalized healthcare delivery. We're going to talk about personalized medicine later on, but personalized healthcare delivery is what I want to concentrate and follow up with John's talk, and then the future of continuous care. First, patient safety has a number of definitions. One definition I like is just preventing unintended consequences. All of us in healthcare and this room have good intentions, as do the sign makers. But that can be foiled if you juxtapose two things with good intentions inadvertently and cause unintended consequences. So the first kid's lesson is, just do the right thing. That's the global message. If you're going to wet the soap and you mess up the towel, you might as well just wash your hands. So we should try to just focus on what it is we're in healthcare for, and that is to take care of patients. So this diagram brings what emotion to you? I mean, when you look at it, what do you see? Joy. Okay, I had a CFO to say that same thing. Spending money. That's if you can see it at all. Can you turn down the lights at all a little bit? Or can you see that already? Okay. You're not thinking about safety. That's the message of this picture. You may be thinking, is this person going to arrive on time? Most of us nowadays do arrive on time. Why is that? Well, when you find something that works and works well, just take it apart and figure out how the heck they did it. And how they did it is by using computers. There's tons and tons of calculations that have to be done second by second in order to keep 5,000 flying objects in the air just in the United States alone. That's got to be the ways, the issues to how do we harness that energy. And they even use decision support. So they don't rely on the human airport traffic controllers. They get these red areas by the computer saying, hey, there's a few extra planes in this sector, pay attention. It didn't make the decision, but it helps advise or provide decision support for the humans. Similarly, the human interface to the pilot, the information display, is so beautifully formed, describes function. So you can see immediately, you can cut this down in two. You have two equal sets of information to two capable people who can pilot this system, a pilot and a co-pilot. In our industry, we should have the same. The other thing is you'll notice this, it doesn't spew out thousands of calculations a second. It's showing an artificial display, artificial horizon, something a mere human can deal with. Okay, switch over to patient safety, to healthcare industry, and what do we have? Same kind of inherent contentment, trust is in that woman's face when she's meeting up with her physician. But what's the human interface with the information? That's not joy, I don't think, but that's what we face, and I suspect you face in your country as well. And what's the information infrastructure behind that? This is the information infrastructure behind that. Unbeknownst to, you don't think of it, the doctor doesn't think of it, the patient doesn't think of it, particularly the patient doesn't think of it, but that's what underlies how we deal with information. And what's the user interface in the most intense and critically important areas where you have to make decisions. So you'll see over 50 numbers, raw numbers, spewing out over this person. Somehow that person's in theory supposed to make and assimilate what's going on, formulate a conclusion, and make recommendations. It just doesn't happen. It's not designed to happen, not possible. No artificial horizon. So if it smells like this is really a bad situation, probably it's a really bad situation. So go back to the patient safety world. What's the consequence of leaving things the way they are? This is the IOM study where it says we killed, just in America alone, 100,000 folks, and that's just the tip of the iceberg. But this is based on a study of 30,000, over 30,000 carts manually abstracted, with an adverse event definition that's actually more stringent than we typically use. So this is something that arises out of the medical management, what we do voluntarily to patients, not the disease itself, when there is death, disability, or prolonged hospitalization. Normally, you don't put the last three in there. But even with that strict definition, about 44% of our admissions have one of these things, 14% of which are fatal, and that's how you get the magic 98,000 lives. And the problem is, over half of them are due to errors that we make. And I don't think it's the people that make the errors, it's the system, the lack of system that we have in our country, and I'm afraid we share it with the rest of the world. So what causes these errors? What causes the harm? Probably it's the way physicians mess up. We don't do it intentionally. That goes back to the definition. It's our unintentional errors and the consequences of that. Now, sometimes we just plain, cut off the wrong limb or give the wrong drug. Those are errors of commission. And that actually is the focus of that 98,000 death rate. What's the rest of the iceberg, I think, is the errors of omission. What we already know and have proven, but we don't do. I want to stress that a bit more. So we knew, this is when I went to medical school, we knew that giving this class of drugs, beta blockers, this is in the popular media as well, saves lives, prevents heart attacks, prevents deaths. 17 years later, we're doing it about a third of the time. Everybody knows that having high blood pressure for a long time gives you strokes and gives you heart attacks. Quarter of the time we got people controlled over yesteryear's criteria. Now we're trying to strive for 120 over 80, so we're even more out of whack. And in one study it showed that 40% of people had blood pressures way over, despite the fact that they were seen more than 6 times in a year. So it's not just that we aren't even seeing them. And then there's this one sort of summary study published by Beth McGlynn out of Rand, which says about half the time we do what we already have consensus in the scientific area as being what's correct. So that's the motivation for what we're trying to do. The way the IOM said it, as summarized it, is, Americans don't get what they expect and what they deserve. This is probably a major point. You can't expect a stranger to wipe your nose because they don't know what's going on and they don't know the problems that underlie the mistakes that we make, because we don't make them intentionally. So it really takes people in this room who have both the tools and the knowledge of what's going on in this healthcare, so-called healthcare delivery system, to fix it. So the solutions, well, there's 3 I'd like to propose. One is really easy, and it goes to that gentleman for the low cost, okay, who worries about cost. We could just simply, at the cost of printing out papers, print out this informed consent. Warning, our physicians and nurses have good intentions, but merely humans using an antiquated paper-based record-keeping system in an attempt to deliver a complex set of services without error. Now, we'd hope that by now we'd have adopted computers like the rest of the world. They haven't arrived yet. And moreover, we now understand the effects of fatigue and overwork and failure to coordinate your care, and we thought, in the name of transparency, you should know this too. So by signing this, you acknowledge that it's really up to you to take care and watch out for yourself. But it's the best we have to offer. And that's the excuse we've had. And there's a lot of impediments, and John started talking about the cost, the knowledge of even knowing what to do, and the culture. But so there's another approach, and surprisingly, in this survey, 40% of patients take this approach, which is maintain your own record system. Why do they do that? In order to prevent mistakes and improve the quality of care. So some of the patients have actually figured out that we don't know what we're doing. Another approach does bring it back to us wiping our own nose and says, you know what? Okay, fine, it's not working. We already said it doesn't deliver what we expect and deserve. Let's go and do that. Let's go and figure out what it is that we expect and deserve, and let's try to give care that's at least safe. And by safe, now this is minus the errors of commission, but also the errors of omission. And you can't do that. So you can either study it and find all the bad apples and all the bad processes, or you can just design the system to prevent the mistakes from happening in the first place. That seems like the more desirable way to go. That takes a culture of safety, a human thing, plus the information systems that would support humans trying to do good intentions. Secretary Thompson, Secretary of HHS in the United States, always talked about grocery stores and how grocery stores are more automated than healthcare, which is true. It is more complex in healthcare's defense. But so he wanted to incent more. Why don't more people use this? And so he wanted to incent people to use this. And then if you ask everybody who uses an EHR, you have 100% of the hands go up. So the next question is, well, how would you define an EHR in a way that would get you the benefits that studies out of organizations like John's tell us that they should be producing? So he asked the Institute of Medicine to come up with a list of key capabilities. What would I look for in defining an EHR system that would deliver the goods? So we had 8 buckets. One is you got to have health information about the patient in there, right? Secondly, results, lab test results, imaging results form such a big part of it. You got to give the doc and clinician more tools than just looking at the raw data, as you saw in the ICU. Thirdly, we have this transcription error. So we write something, nobody can read it, somebody else writes. So this on and on and on perpetuation of mistakes. Cut that out with the orders management. Manage the orders and get them there. Reformat it for the uses of the different people on the team, but don't copy it over and over again. And the most important part is decision support, because that's influencing the decisions made primarily by docs to get it right the first time. We got to connect the dots. Somebody mentioned over here, you can't just hoard it in your own institution. It's got to go everywhere, including to the patient. And then the patient has to have tools, too, in order to participate in their own care. And we have to, as a society, deal with population health, biosurveillance, and so on. And then we do live with administrative procedures, whether it's claims processing or eligibility. That's all interdigitated with what we do. That, by the way, is on the web page. You'll have it in your CD. So if we were to automatically overnight do this, is it going to do us any good, or are we going to have more of the ICU situation with just yet another box throwing out numbers to the doc? I did an interesting study, it's probably now unethical, of a large internal medicine department and gave computers to half the group. So at that time, about 10 years ago, it was unethical to make to half the group use the computer. Now it would be unethical to deny the other half the use of the computer. So what we did is randomly picked patients from each of the doc's group and then sanitized them and typed them up in a similar format. And then gave it to a blinded expert panel, some of the most revered folks in Chicagoland, and asked them to judge the decisions that were made, the things that are decided for patients. On a scale of 0 to 5, 0 is totally inappropriate. 5 is totally appropriate to these Monday morning quarterbacks where you can look at the record and judge critically, and then 3 is neutral. Well, when they looked at the records of people who were using paper that we rely on average they scored 2.5, which is, as you'll notice, it's actually on the side of inappropriate decisions. And when you looked at the docs who were using the computerized record, they did score statistically significantly and I think clinically better. So the bottom line is I think we do make better decisions with availability of information. The real point, I think, and the point of the future is really involving the patients as part of the healthcare delivery system. That's such an untapped resource, and John started talking about that in terms of the remote healthcare. And the questions in this area talked about patients as being part of their team. And so I just want to share some of our experience, and that's been truly rewarding. So in this screenshot, basically patients logging in. We go through an extensive authentication process, and then has a series of things that they can do over the web, over the internet. One of which is request an appointment. So I'm going to walk you through a scenario. So this person's asking for an appointment because back pain. Has had back pain in the past and now lifted her granddaughter up and injured it again. Now we actually have implemented a process called open access. So you will get an appointment with your doc today over 80% of the time. So she has to actually run in to get that appointment. So after she's had the hands-on, she sort of rushes back because she wants to find it. So we've given her a handout of instructions, but that's actually not good enough. Now we give her a web page that's the same thing. So she'll go and look at her visit from today and have the same instructions that I went over verbally, but also printed out for her. So these are those instructions. But also gave her, now back pain is not something you magically treat. There's no pill, and yet it's a huge disability, cause of disability and cause of time away from work. So it's a big financial impact. But it's a prevention scheme, not a treatment scheme. And the prevention is really to do things that prevent the next one, not necessarily treat this one. And that's where we fall down as healthcare providers incredibly. Because, in the office I might say, well, do back exercises, and it won't happen to you again. The patient's too bashful to say, well, what are back exercises? The doc's too proud to say, I don't know. But there are simple pages on the web that explain what it is. And the thing is, you have to know later on when you're better, not today, because you're motivated to do it today. So the time is, it's all about timing. So the next time she comes back and she now is over her back pain and she's ready to do those exercises. And the question is, do I start now? That's the teachable moment. So most of the time, if you say, well, I'll just call the doc. If your call system is anything like ours, nah, I'm not going to do that, which means, no, I'm not going to do the exercise, which means I'm going to have the back pain again. So at this point, 24 hours a day, she can ask her question, and that'll come in to the doc's in basket, which is the same place where the doc sees lab test results, gets messages from his nurse, and so on. So that's the important part of the workflow, which is part of engineering design as well. She'll get a message back and says she has a new message, and it gives the doc feedback, which is automatically, in the electronic world, unlike the paper world, captured in her electronic health record system. Other things she can look at parts of her medical record, like the list of, we call it the problem list, we call it health issues on the patient side, all of her meds that we have on record, her immunizations, her allergies, and she can correct those, and her health maintenance schedule according to her risk factors, not just the generic thing you can find on the internet. She also, and this is one of the most popular features, is she can get access to her lab test results. Now, she can get the raw numbers and the normal limits, all that kind of stuff, but more importantly, she's going to get advice for interpretation and future recommendations from her doc. That's what she's interested in. We also, you'll notice that we have these hyperlinks. Now, at one point, we gave docs a library of hyperlinks, and it was used just like the books on the bookcase, which is not at all. So what we decided to do is make it happen, which is, in general, in our world, you make it happen by doing it for the docs. So we now use a technology where we'll find all these things. It's not hard. We know LDL comes up a lot. We know low cholesterol diet and back exercises come up a lot. Automatically find them, have the computer find it, create the link itself, and then bring you up to a page where we've handwritten a definition in human speak and hand-selected what web pages would bear on that particular ailment. This is sort of the personalized healthcare piece that I was talking about. This is now getting into disease management. Numbers are great. The impact lasts about 5 seconds, 10 seconds at the most. What lasts better is if you can present information in a way that impacts human behavior and emotion. So the down trend is in response to me taking the white pill is what causes the change, not telling you your number's 135. It just doesn't work. We know across the board, patients take only about half the medications that are prescribed. So that's the missing opportunity, not beating up on the docs. We started this in 2002, and our enrollment is steadily increasing. The slope is increasing, if not, certainly not decreasing. We have now over 33,000 patients, which is about a quarter of our practice. So a quarter of our population is already online, and we want to just shoot. I don't know what the asymptote is, the plateau, if there is one. So we do annual surveys. This is from last year, March. 90% were satisfied, score of 4.3 over 5. And they like these things. So they like the lab test results. By California law, we actually have to return results. We obviously didn't. So they like the fact that they get them, for sure, absolutely 100% will, and they get them in a timely way. The other piece is John talked about this financial incentive piece. So it's, quote, free now, in the sense that we aren't reimbursed for anything that can be done more efficiently than dragging you into the office. So what we've done is we've put into place a nominal fee, $60 per year for unlimited message. So everything's free except for messaging to your doc, because we think there's a professional component of that service, and so we made this nominal fee that we don't think would be a barrier, but does recognize the professional component. The important piece is docs are satisfied too. If they weren't, this wouldn't work. So right now, first of all, it's mandated. All of our docs have to use the system, just like they have to answer the telephone. And the other piece is it is more efficient for them, and they get positive feedback from the patients. That's why the whole thing works. Wanted to share with you I got over 5,000 Freeform text feedback in our last survey. I want to share with you some of those comments because they're very illustrative on the transformation that's going on. So this person said it changes totally the dynamic of healthcare. It sort of levels the playing field. Another person said she declared she was a nurse in her 80s. I'm saying it's a she because most people who are in their 80s who are nurses are going to be a she. Saying it's important to her because she may be somewhat physically impaired, but she's not mentally impaired, and this tool bridges that gap. This person says, allows me to be a part of my team in taking care of myself, and it's referring to the lab test results. And this person probably was an engineer. I always check my lab results, tailored my diet to adjust my lipids, and saw the improved results. Not only did I decrease my triglycerides from 333 to 85, but voila, I lost 20 pounds, which wasn't the... Okay, and this person attributes it to the online test results, the thing that by law we had to give to them. But I think it was the graph. Another one, person in the lab, out of the lab, and later that afternoon basically plotting my results. What they're saying is I like having access to my own information and being able to do something about it. This person just likes the, gloating over having something somebody else, a neighbor, might not have. And this person described it as not a website, but a good deed. Isn't that what we owed our patients in the first place? Because we're providers, servants to the patient's needs, and we never did share the information or the tools to make a difference with it. So I think one of the things we're trying to do is create an experience and an enabling experience for patients to help participate on their own team. Continuous healing. So what the future goal? An unobtrusive, seamless, continuous monitoring and management. I mean, that's sort of the future vision. And what John was talking about is sort of the infrastructure for that future vision. Unobtrusive would mean sort of it's non-invasive. Unobtrusive doesn't mean, you stick yourself or jab yourself to get blood, to sample glucose flowing around your bloodstream. And it's plugless and play. It's not connecting up to the RS-232 and configuring the IRQ. That's ridiculous. It really has to be plugged, while you just do something, you just put something on for 15 seconds and then things happen. That's the way it should be. Just-in-time information and knowledge means, they don't want to read about diabetes or high blood pressure in abstract. They want to know it when they have some kind of symptom. And then care anywhere, again, was what John was talking about. So if you think about it, we start with Adam and Eve. Even Adam and Eve got sick. But they're constantly emitting signals in real time. And our problem is we don't have the instruments to capture those signals or interpret it. And then we create some system of, well, I think I should see in 3 months. I don't know what's going to be going on in 3 months, but that's my sampling frequency, which is totally unrelated to physiologic symptoms. And then we have multiple care providers. We go into this big gray building and completely divorce ourselves from other parts of your record and other parts of your information. So instead, we really got to find a way to capture those continuous signals and interpret it or triage it so that we get notified when there's something that we need to intervene on at the time, not to some randomly scheduled, in 3 months, which is May 17th, whatever is happening on May 17th. It doesn't make any sense. It doesn't make any physiologic sense. And be able to sort of in a continuous way capture what's going on interpret it, process it, and render feedback back to the patient. So that involves devices, it involves the infrastructure that John talked about in order to get care. So fortunately, I'm finished as well. So what we do now is not good enough. It takes EHR systems to get there. It takes systems that engage patients to be a part of their team in order to get seamless, continuous care. So if we look out into the future, what would prevent this from happening? Just ourselves. Our lack of openness to change. It says, mind your own business. This is how I like it. So the final words, you're either chasing or you're being chased, and it's much better to be on the chasing side than the playing side. And that would be the advice my kids give me. Thanks very much for your attention.
So now we'll hear from our panelists, and I'll start from the other end, from Keith.
That was a great presentation, and I think I agree with you. I think that's definitely on the mark of where things need to do to be corrected. You know, as a radiologist, one of the challenges that we have is we're essentially servants to physicians that order exams for us to go to our patients. And there's almost been, you know, I've been in for 10 years, and I had a little trouble adapting to the fact that even though we are the stewards of this information, we should be very focused of who we give it to and who we do not give it to. And even the question comes when you're about to publish, who owns it? Is it the insurance company? Is it the patient? Is it the hospital? Is it you? Is it the referring doc? And so this ownership issue and security issue seem to really snag a lot of the advanced movements that we could be making toward delivering this information. Is that ever going to change? Is there any progress anywhere, any place where people are just cutting through all of these issues?
Excellent question. And first, I thought you were going down the, you know, you have to do what we order. We let our radiologists do what they're supposed to do, and change. So that's one thing. We have to relinquish it to the experts. And the other piece is you talked about ownership. It's of course the mantra: the patient owns the data. So more and more we are giving that information to the patient. So in fact, when I said 100% of our lab tests go out, it's not because 100% of our docs are releasing it right away. We just made it so. So once they touch it, unless they specifically sort of untouch it, it'll go out that instant, which is why patients are seeing it that afternoon. And if they, no matter what they do, at 10 days, because we have service agreements, our docs have to release, present data back to their patients by this, and this, by varying degrees of abnormality, then the computer will just do it. So I know that 100% of our results are going out. Radiology was an interesting thing because all the words we used to use in the head and stuff. Well, we just now turned that on so that we'll be force-fed out to the patient because they own it and because they're our last safety net of patient safety. So in fact, one of our pap smears went out to a patient, and it was not malignant but abnormal. And surprisingly, the patient comes back, "That's nice, but I didn't have a pap smear." So we found out that it was mislabeled. So somebody else who has an abnormal pap smear now has that information because this. So there's always a safety net to it. So what we did do is we went and linked. You know, I showed you how that we automatically hyperlink things. We found all the common things that you guys say and put them into English, so that one of the fears. Now that's frightening, I know, but one of the fears is that, you know, patients will call me up all the time. It doesn't happen. Patients don't do that, and they don't overburden the system. So in some sense, we're already going the next step of it's the patients who own it, and we now move it out to the patients in dealing with some of this information, and fortunately or unfortunately acting as some of the backstop from a patient safety point of view. So I think over time, another thing we do is based on our EHR, you know how you have report cards, and typically what happens is you get your private score and you get to compare yourself to your group. In our system, you get your private score and compare to the group, but then there's a pick list that says, and I'll see anybody's private score in the entire system, and that's on our intranet. I think it's only a short period of time when it's going to be on the internet. So I think there's a lot of self-correcting that we have not applied to the system, that the tools now are in place that we can now try to move that way. And it's going to unleash an incredible resource. We don't have the resource to see everybody in the office. So we need to take advantage of patients. And I think one of the themes that John started was we've got to start involving the patients, the consumers as part of that team. And I think we need the technology and the workflow and all of the technical infrastructure to do that.
You mentioned the electronic health record as a mechanism to decrease errors, and I agree completely. One of the things that we've struggled with is how do you get physicians to interact with the computer and input information into the computer? It's interesting. We're seeing sort of a culture where there are three groups of physicians. There's kind of the ones who are just coming out of medical school, who are from sort of the instant message generation. We've got a slightly younger or older group who at least will do email, and then we've got a whole large group that really never learned how to type. And so we're struggling with how do you get them to input that information. In some cases, I think our patients are better than many of our physicians with regard to interest in interacting with the computer. And so we try to use a combination of speech recognition and of typing and other types of input devices. I just wonder what your experience has been.
Yeah, excellent question. When I first went to Northwestern, that was 1994, nobody had computers, the docs, even at home. And of course, there was no email then. The way we got them to type was to give them computers and email. And so we never got the question, I can't type. They still can't type, but email became part of their life, just like the instant messaging of today. And they did that for other than professional reasons largely, but it became, you just had to make body contact with this device. And so that's how we got over the initial piece. Then when I talked about it being unethical then to force half of them to use the computer, it's true. They were there kicking and screaming. But then you started realizing that you're actually a better doc and your patients actually recognize that when you know something. So the big embarrassment is you make a change, and when you see somebody, you're going to see that person soon, not later. And so you would like to know what you did the last time, whether it's a phone call or an office visit. And that embarrassment, or reducing that embarrassment by having things in the record that you could access, is, I think, drove a lot of the people why, particularly primary care, would make sure it gets in there. One of my first insights was the second weekend after we'd gone live, was on call, and got this call from somebody, an elderly woman in the far western suburbs, and I go, at 11 o'clock, I knew I was going to be up all night. I said, well, I'll just check, because check the electronic health record just in case it's there. And lo and behold, it was there. So she had been seen that week, and I was able to short-circuit the entire visit. And then the insight was sick people get seen. So the very people whose data you want to get in there gets in there faster than most. And so it just really actually builds on itself. So it's through lessons like that, I think, that creates the positive reinforcement for people to do that data entry. It's still a lot of work, no question, and I wish voice recognition was here. There are, in radiology, there's certain niches where it does work, but for an internist, which is what I am, it doesn't work so hard. I actually use it, but it's just replacing the way I spend my time.
Just one quick comment. Actually, the term ownership of medical data is irrelevant legally. It's not actually, you have differential rights and responsibilities because you, the owner, don't have unilateral ability to control the use of your portion of the asset. So anyway, that's just a sort of set of special. But Paul, and this, you've heard this question before, why is it that one sees very high adoption rates in the Scandinavian and many Commonwealth countries and such miserable adoption rates in the U.S.?
Because as Churchill said, we try everything, we fail at everything before we get it right. We're just so autonomous, I think. We're so reluctant to give up our autonomy, whether that's as individual consumers or citizens or docs, that we don't let what seems like obvious things come to pass. So I think a lot of the Scandinavian and the UK, or countries where they have more penetration of these things, I think they've taken much more of a central approach to it. And sometimes it works, sometimes it doesn't, but it's sort of a more of a benevolent kind of a central control thing. It's part of culture, and it's just anti-American to let somebody else control your destiny, I guess, even if it's for the common good. And I think there's a lesson to be learned there. Does that make sense? What's your thought about that?
Well, I think there's a cultural Wild West cowboy, even if none of them were ever around during that period of time. The other is that because of that, the financial incentives have to work differently. I mean, if I'm going to take it out of my pocket and make it what's in it for me, then I want to see cash moving my way. And right now, the reimbursement structure doesn't exist to do that. Above and beyond use of the technology, whether we can type or not type, or whether it's
Right.
well designed or not well designed.
And so two good organizations as models or examples in our country is one is the VA, which basically owns both the provider side and the payer side, and the other is Kaiser, which, as you probably know, has a $3 billion initiative going on. And again, it's the payer side of Kaiser that's paying for it for the provider. So in John and my case, it's the providers who basically have a low margin that are paying for it and having to put up with the use of it that are implementing the systems or trying to. Thanks.
Paul, very good talk. I was curious to know, what do you think about the security issues, especially, I mean, I as a patient would be very concerned if my records are seen by a health maintenance organization, which says that after a certain time they see my deteriorating cholesterol levels, and they say, gee, I'm going to cut you off insurance at this point in time. So how do you deal with the issue of who sees it? Because electronic health records have this issue of security and safety. Do you have protocols that deal with this issue?
Absolutely. And I think there was a question on accountability, and I think that we do have a personal accountability. Taking away the payer, because that's a bit of a so we do have stronger laws in the U.S. It's called HIPAA that has, if nothing else, increased people's awareness on what's the rights of patients, because I think we were very sloppy before. And ironically, even though you think you put in the computer, you know, it may be more open to malicious attack. One, people aren't that interested in your health record, except for people with financial gain, and the people with financial gain can get at it anyway. But we're actually much more careful about the way we put it into a computer, and we have the most powerful tool, which is we have audits. So we have fired many more people after the computer than before, because we couldn't fire anybody before because we could never catch anybody violating the policy. From a payer point of view, unfortunately, in our system, you know, someone who's going to pay for your care has the right to see what you're getting. Now, they actually don't have the right to your identifiable cholesterol, thank goodness, but they can ask for it, and they do. And we should, as providers, provide things that give them a way of analyzing the population, but not you individually, because of things like that, like discrimination, as you mentioned, the risk. Does that answer your question? Yeah. Or at least
What
start
I'd
to
like to
address.
do is, if I could, take questions and comments from the audience. And in terms of microphones, we have, I'd like to start on this side if I could. Okay. Any questions or comments from this side first? If not, okay, right there. Yeah, no. Over here. Wait. Macy.
I have a very simple question relating to the responses you had.
The-
I know the responses from patients and from physicians, and I noticed that you had some negative response. You know, the percentage was less than 100. And my question is, was there a common thread in these negative responses, and and could you use it to improve the system?
Yeah, absolutely. On the provider side, we're a multi-specialty group practice, so we do have orthopods. That probably explains. Clearly, not everybody wants to spend the time that was asked here to enter in information or thinks they have to, and that would be. And not everybody wants to have that close connectivity, but fortunately, the majority of us do. On the patient side, again, it's individual. So their experience is determined by how quickly and with what efficacy did the other person respond. And just like we have any other spectrum of human behavior, we have docs who aren't as conscientious about getting back to people, and typically that's what they're dissatisfied with. So there's a lot to who's participating with which vigor. And of course, there are people who want even more. So we keep exposing more and more data. So even before, they may not have had access to the radiology tests. Now it's so, and it will be so, and those kinds of things.
Friendly.
Could you comment on patient safety as it relates to the information technology itself? I'm thinking of what happens to, if a network goes down during a telemedicine session, or if poor user interface design contributes to user error.
Excellent question. So let's talk about the downtime first. Downtime is extraordinarily painful, and it's politically costly. In the past, in the paper world, the system is down individually about 30% of the time, sort of in the study. So I'll not get 30% of my records, so it is down, but it happens one at a time. and you just don't find anybody to blame. You can't blame paper. In the computer world, it's interesting. Our expectations change. Computers are not supposed to go down, and they're supposed to be instantaneous, both of which, the lack of achieving both of those gold standards causes dissatisfaction. But we have to start working through that. From a patient safety point, in fact, there's an article Joan Ash wrote, and also I did a little web article about how IT can facilitate error. So just think of a pick list. You can pick the wrong thing in a computer, and all those things can happen. Or you make a wrong entry in the master table, and all of a sudden all those orders could be wrong. So those are things we have to worry about, and we actually should study, I think. But if you look at it, probably there's a lot more eyes looking at these major systematic errors, and we also can track what happens. So, I mean, that's not an excuse or justification for having any kind of errors, but I think it's sort of the impact of those systematic errors that have a lot of eyes could be attenuated. You know, the negative impact could be attenuated. But I think we need to be more vigilant about that. We don't worry about it enough. You're absolutely right.
Maybe what I'll do is I'll take a couple more questions over here. Okay, I think
I have two questions. The first one is many companies are going after the space, the EHR space. And are going after the EPRs, the space. And at the same time, studies shows that big hospitals invest in their IT department to develop those systems. And I'm just curious in your comment on that. It's a contradiction that exists. And it's the first question. And the second question is, is anybody thinking of concentrating this information in patient hands? And instead of having because the major problem with dispersed EHR system is to share information across enterprises, across regions, maybe there is a place for the paradigm where patient information is stored in his hand.
Let me answer the second one first, which is there an interim way where patients can be the aggregator of data, since they have the most vested interest, while we techies try to figure out how to get data from one system to another in a meaningful way? And actually, I think the answer may be yes. In fact, in the U.S., this PHR concept, although still ill-defined, I think is one that's sort of gaining momentum and may be one of those intermediary to handle the short-term situation. So I think there may be a lot of wisdom in what you're saying and a direction that we should be going in the short term. The first question, I want to defer partly to John, because so John's group basically led the way, I think, a lot for the world in terms of, one, developing these things when there weren't any vendors around and proving that they work. So that's invaluable. And then the question is, when is it ready to turn over to the private sector to continue the development and dissemination? I think we've gone over that cusp. So there are mature vendors out there now who are, and it's not everybody in the field, who are delivering products that fit some of those 8 buckets in an evolving way and are on a pathway. And I think most of the provider organizations need to take advantage of that solution. And John can comment, I'm sure, about the trade-off between self-developed and commercial at this time, or maybe in the past.
We do a phenomenal amount of internal development. So we have a 1,200-person IS staff, 200 developers, and a large medical informatics group. And the question is why? I think to a degree, organizational inertia. So you do it for 20 years, you tend to see all problems as development problems rather than acquisition problems. That to the side, you make a fundamental strategic call that says this class of systems has one of 2 properties. One, it's an area of extraordinary amount of experimentation that we would like to do in the years ahead. And we do that because we're a research organization, or we believe that there are, in fact, some fundamental questions that need to be answered that we're in a position to answer. The other reason is that there's sort of an experimental mode. The other reason that you can do that is if you believe that getting a superior result here has very significant strategic strategic consequences to the organization, and you have either the arrogance or the correct belief that you can do better than the rest of the world. And so you believe that you can buy an A product, but you can actually affect an A+, and that has material consequence. You could have an A+ email system and nobody cares. But if you had an A+ way of delivering clinical decision support, or in Shankar's realm, where we're now looking at the influence of genomics, that being ahead of that curve and being early on integrating genomic, proteomic, and phenotypic information has material sort of strategic consequence. That's the reason you do that. So this ought to be a thoughtful exercise, and I think in most cases it's inertial, frankly. But there are times when, in fact, there are real reasons to engage in the development. You'd better be good at it because you can create mediocrity startlingly quickly.
Okay, let's hold on that for 1 second. We'll come back. Questions on the right side? Maybe you have a question over there. David?
I enjoyed your talk, and particularly the focus on patient safety. Just as an aside, in Canada, we've done a similar study with similar results in terms of scaling for population and things. But when it came out, a lot of the work had been done carefully in the background to make it so that what we were able to say was Canada is as safe as United States, Australia, New Zealand, Great Britain. And unfortunately, and I really, as a clinician, I loved your talk because I'd love to work in that clinic because I think what you're doing is the right thing to do. But I think that the challenge is the decision makers don't necessarily get support for those kinds of innovation and changes. But I think seeing it working is a lot of hope for all of us.
We have a question from Kathy and then from here. So could you, where's the microphone on this side? Could you pass it to Kathy, please? Kathy.
Hi, I also enjoyed your talk. Right now, we're conducting a study in a hospital in Toronto, and we're actually tracking the use of electronic patient records in a ward. And what we're finding is it is pretty much of a dog's breakfast in terms of what's happening. There's the existence of ghost records, for example, where print-offs are made, ubiquitous use of Post-it notes across the records, and a huge social factor in terms of the way these patient records are being used. So my question to you is, it seems to me there's a real bottleneck right now in the hospitals with respect to electronic patient records, because it really is a question of garbage in, garbage out in terms of the information that's going into them. Is there any research that's actually been, one of the factors, by the way, we're quite convinced, is the actual visual interface that's causing a lot of the problems. It's a textual visual interface that they're using, and they've got 3 competing interfaces that they're actually using on this one ward. So it truly is a mess in terms of electronic patient records. Is it, in your view, is this more of a social problem? Is this a design problem? What's happening in terms, particularly the hospitals and the teaching hospitals in particular?
It's an excellent question, and I think it is a systems design problem. The way you get data, good data in, is by making it reusable and reused. So before, let's say diagnosis, for example, we made policy decisions nationally based on claims data because the government's the largest payer in the United States, as it is in Canada, and you just used the claims data and what the diagnoses were on this claims data, not realizing that the workflow is such that often the clinician and docs are divorced from the claims side. You just submitted billable diagnoses. And you can draw terrible conclusions scientifically and epidemiologically based on that data. And why? Because the doc didn't care what was on the bill because I never reuse it. When we put it on the problem list and we reuse it the next time we see the patient and reuse it when we order the next test, all of a sudden it's in our vested interest to make sure that that's up to date. And then when we do that kind of scoring thing and make it public, all of a sudden it's useful to know what's the context, the severity adjustment of my patients. So it's putting in the loop the incentive for having high quality data, and the way you do that is make it reusable. That's a design thing. If you make, I mean, let's take the extreme. You enter in the diagnosis every time you need to order a med or a test or a bill, then there's no incentive, and it's just extra work, so physicians won't like it. You enter it once, and you reuse it for all 3, and all of a sudden the quality goes up. So it's what we have to design into it. And then the how hard is it to do the right thing, that's a system design and a user interface issue. So there's tons, and your question was among them. of value and contribution in the user interface issue and the workflow.
It was an excellent. Yeah, I'm here.
There.
It was an excellent, let's say, snapshot of what you're doing today, and a horizontal view at the level of the hospital and the community there. But my question is, we are talking about the future. Suppose that everybody has patient records, 100% operational. What are the further steps in the roadmap? Can you use these data, for instance, for public health?
Sure.
And is this possible in the United States?
Right.
Because this is the question about the Nordic. I think the Nordic, they
Right.
have a public statement on healthcare
Right.
and how to use all these things. And how should this run? And can you put some time frame on it, like when should we go and move to content? How can we balance quality against cost?
Right. Good questions. You started going down the path of public health. We talk about randomized clinical trials, yet we also talk about how we don't know much. So in a sense, we're running uncontrolled trials with almost every patient and throwing away the data. Clearly we did that with paper, unless you would invest the hundreds of thousands of dollars to figure out what happened. All of a sudden now, we have the chance, I say chance because we still have to do a lot of standards work, we have the chance of capturing the million transactions and experiments that are going on and making sense of that. That would be not only public health. So right now, the way we do biosurveillance is sort of capturing, again, claims data from ERs. We need to capture clinical data transactions and make biosurveillance a byproduct of care. So I think the way to tap into this is to be able to gather standardized clinical data, take advantage of it for these other uses, whether it's public health, biosurveillance, or research. Research that may not prove something, as an RCT trial would, but at least would address the questions that need to be proved. And the first part of your question, I think I may have lost.
Yeah, and then cost quality.
Cost quality. We are going, again, John emphasized this a lot in terms of the lack of financial incentives, what kind of a barrier that's been. Fortunately, we do have some influential people. The head of the government pay system, which is called CMS in the country, runs Medicare and Medicaid, is a doctor and an economist and a visionary in terms of understanding that we can't continue the same pay for complications reimbursement policies we have. We have to pay for healthcare outcomes, and are moving in demonstration projects that way. So I think the issue is, first we need a bootstrap mechanism, because it just costs a lot to get the system in. Then you have to prove that you are doing good with it. And that's where the pay for performance, pay for quality outcomes comes into place. So I think we need both of those almost at the same time. But we're evolving right now in this pay for performance structure, but we have 1,000 of them. So that's, again, going down the wrong path. We need to have one, in a sense, so we can all work off the same reports. But those are key issues.
We have time for one more question. Again.
Paul, today we are focused very much on patient-to-provider communication. I wonder, how do you feel about patient-to-patient communication and knowledge sharing?
It's a good question. The risk is privacy, because if you can do this in an anonymous fashion, and I think there is a great value in what are called our chat groups, and particularly disease-centered chat groups. So, in fact, we actually have one of the ways we deal with our access problem is by having group visits. You may think of group visits in psychiatry, but there's group visits for arthritis or acne as another example. And what you learn is learning from other people who have to deal with the same conditions, whether it's acne in your social life or it's arthritis and the ways it affects your activities of daily living. But that's part of the therapy in itself, and there's no reason that need only happen face-to-face. In fact, you have better privacy and anonymity if you do it on the web. So I think that's something that could be done. What I'd like to do is also have it moderated so that there's some additional input from the professional community. And then again, we have the problem of, and then who pays for these things? And if I mean, somebody's got to put the technology in place and so on and so forth. So there's a lot that could be done in the financial incentive and policy making domain that would help facilitate a lot of this stuff.
Okay, we do have one for whoever feels the worst about my overlooking them. If not, will give us just 1 extra minute to change between speakers. Says Paul, thank you very much. By the way, I'd ask you, what I try to do is, if you put your hands up and I don't see anything on that side, what I'm doing is focusing on this side because I have a lot of questions. But if you put your hand up, I'm trying to memorize and go from one to the other as best I can.